Welcome to the recording of the Community-Based Organizations feedback session. In this presentation, I'll be talking about the findings from the focus group discussion preliminary analysis, and I'll give you a little bit of background on that in a little bit. But I just want to start saying my name is Betelhem Muno, and I'll be giving this presentation on behalf of the N3C team members. This is made for individuals that want to look at it again, or those that weren't able to make either of the CBO feedback sessions that we held in June. So just to give background or the agenda, we're just going to do some acknowledgements and background, and then really get into some of the findings and with a discussion and feedback Jamboard if you want to, which I will provide the links for. First, I just wanted to acknowledge the lands that I'm on, as well as encourage you to be kind of just acknowledge and understand whose land you are on, as well as some of the issues, and understand some of the steps that you can take using this link below. I also wanted to say thank you to Rahel, Stephaun, and myself, and the other team members, Miriam and Shukri and Rena, with guiding and making this work happen, as well as all the other collaborators. And then also I want to thank the CBOs and the participants. Really, the meat of this community engagement is because of you guys, so thank you. So to give you a background on some of the work, there are many big data science efforts that are happening, trying to highlight the social determinants of health factors that are driving the racial and ethnic inequities in HIV and COVID. But there's really a missing piece of community engagement. And so the goal through here is to add community engagement component, but specifically really trying to co-create the scientific agendas in a more meaningful way, such as using community-based participatory research or the good participatory principles, and just like to really help shape the next generation of U.S. ending the HIV epidemic interventions, like those goals. So ultimately, the main goal is to formalize and build up the community partnership components of the broader work within N3C, but specifically really focusing on individuals that are affected by, are more vulnerable to, or at elevated risk for, or living with HIV, and who really have the lived experiences in this work, really getting them involved, as well as leading and creating like what needs to happen next. So this was approached in two ways. One was using the scientific advisory committee, so that consisted of community members with lived experiences, as well as scientific individuals in the scientific community. And then the community-based organizations were the ones that conducted the focus group discussions with their own community members, as well as there was also a little bit of overlap between some of the community-based CBOs were part of the scientific advisory committee. The leadership for this was Rahel, Rena, and Shukri. And then for the CBO, it was the late Dr. Stephaun Wallace. Erica, myself, and Miriam were helping with making it happen. CBOs were contacted and sampled through networking, especially Dr. Stephaun Wallace's network, and they were spread across the whole country, across different populations that were being served, as well as like types of organizations. So there were 9 organizations that were approached, and then 8 agreed to participate. And then they were compensated for $1,000 for each focus group discussion that they did conducted, and then each participant received $150 for participating. And then um, to do that, we provided a focus group guide that kind of included the main domains or the main areas that we were hoping to kind of people to discuss. And so it was like social determinants of health and HIV, social determinants of health and COVID, and then the overlap between those two. We also wanted people to discuss the like research priorities that were missing, and then as well as what types of interventions they felt like were missing and needed to be implemented. There were 10 focus group discussions that were conducted between February and May. And then these were analyzed through inductive coding and deduced, and then we did some thematic analysis, which we'll be presenting in a second. All right. So these are the organizations that we had. 2 of them did 2 focus group discussions, and then the rest did 1, so it go 10. When we're looking at the distribution, demographic distribution, we see that or the majority of the participants were younger than 50, as well as half of them identified as LGBTQ plus, and then most of them had some college or more education, and there were about a third of them were social work slash care services. When we're looking at race and ethnicity distribution, majority of the participants identified as Black or African American. When we're looking at their gender identification, about a third identified as cisgender women, and then 20% identified as transgender women, and then a little less than 40% identified as cisgender man, and about 8.6% identified as non-binary or non-conforming. Okay, so now we're really getting to the meat of it. So I just wanted to go over what the social determinants of health was, just as a reminder. This is U.S. Healthy People's 2030 definition. This is broken down into 5 domains, which is looking at education, access, and quality, healthcare access and quality, and then economic stability, and neighborhood and built environment, and finally social and community context. These were broken down during the conversations. So when we looked at education access and quality, they talked about the miseducation and information overload, as well as just like lack of inclusivity in the sex education topics in schools, and then as well as a stigma of HIV leading to avoidance of HIV related education efforts. And then when we're looking at the economic stability, people really talking about housing insecurity, food insecurity, income insecurity, and as well as like thinking about people's their status, their migration status, and generational wealth as a cushion for certain communities. And then when we're looking at social and community context, social isolation and networking was brought up, and it was even brought up in some of the feedback sessions. And then intimate partner violence, as well as internalized racism, and just really some generational differences that people saw. And then as well as lack of representation in the decision making. And then we're looking at the neighborhood and built environment. Again, housing insecurity was brought up again. The different under-resourced neighborhoods and how that influenced transportation, food access, medical access. And then as well as apartment sizing and crowding and health and social distancing. This was really felt during COVID. And then they also were talking about the relationship between being unhoused and mental health, as well as like other types of health. And finally, when we're looking at healthcare access and quality, um, they were talking about many insurance barriers and complicated health systems, as well as poor mental health services, lack of cultural competency, and then also just like lack of having a consistent provider, and the like kind of the relationship between or the barrier between like contact tracing, but then as well as people's immigration status and the difficulty with that, the and then also just understanding that this is part of the historical medical discrimination and violence, which ties into the next section, which really was brought up was these domains or these social determinants of health domains aren't separated. They're all they intersect. And a couple examples that was brought up were economic stability and healthcare access, having to choose. Someone gave an example of having to choose between financial stability, especially among immigrants, and one's health, and then as well as community influence on health and education when it came to judgment and shame from community members, leading to avoidance of HIV education, testing, prevention, and treatment. And another main thing that kept coming up was like one, structural racism kept being brought up as like possibly being, is this a social determinant of health? And another, and then most of the time, it was also brought up as structural racism the main issue to this. This is causing all of these other issues. And so that was kind of the big takeaway. And yeah, which I will get into in a second. But before I do, these were kind of just a couple of examples of the like intersectionality of the domains and people's experiences. You can pause here to read it if you want. Yeah, so this is just a link to the feedback session, which I will share in the email that you received this with if you want to add to it. Okay, now it's findings on the structural racism. Um, they discuss how structural racism forms narratives, stories, and perceptions of people, and structural racism underlies the SDOH influence on HIV and COVID. One of them was policies, generational trauma, symbolic violence, and intersectional forms of oppression. And there was also overlap between HIV and COVID-19 experiences, such as like the need for self-representation in health, advocacy, and self-sustaining resources for minoritized communities. So ultimately, though, everyone was defining structural racism in different ways. And this is not the way of defining it, but this was one of the ways that some of the ways that individuals within these focus group discussions defined it and experienced it. Sorry about that. So when it comes to policies, they were discussing like how policies were as determinants of services, experiences, and resources, and like they were the foundation for health disparities. And much of the conversations were around decision making power and and as well as yeah, decision making power and like representation. And then generational trauma came with the avoidance and mistrust of healthcare systems, the misinformation some communities get, for mental health and how that's passed down through generations, and then how some communities, specifically white communities, often have generational wealth and access to resources, and many people were just like they weren't experiencing that. Um, and then another thing was symbolic violence. So many people felt like the systems were inherently anti-Black, and there was a lack of representation across all the different spaces And like some examples were like providers dismissal of pain or experience. And then there's also again the intersectional forms of oppression. So people experiencing homophobia, transphobia, sexism, and then colorism and xenophobia even within our own communities, and as well as white LGBTQ plus priorities, especially when it came to like policies or different like access to resources or or experiences. Again, these are a couple of examples which I encourage you to pause to read. So we really were thinking about what models, what ways can we understand and visualize this? And obviously, there are many models that already exist that try to visualize structural racism and social determinants of health. There are few that combine both of them, but we really wanted to try to find a way to visualize or see the experiences that people described and in these focus group discussions. So this is an attempt at it. Obviously, this is the preliminary analysis. So, but yeah. So this is one attempt at it. Um, so this is figure one, and this is really trying to look at structural racism, how these experiences manifest, and then, or how and then how that's tied to social determinants of health. So here's like kind of the foundation of structural racism, and that shows up through policies, generational trauma, symbolic violence, and intersectional forms of oppression. And then these manifest in many of the ways that I described above through decision-making power, through anti-Blackness policies for mental health. And these are just examples. They're not even encompassing everything that people are experiencing and that are through the structural systems. And then these show up different ways through all the five domains of social determinants of health, which again are overlapping, are not like by themselves. And so, yeah, this is our attempt to really capture those experiences. Um, and yeah, so this is again another opportunity to give us feedback on how the relationship you're seeing the relationship and what changes need to occur to happen to it. A lot of this discussion in the feedback session happened throughout the meeting, but here's kind of just summarizing everything. There's intersection of SOH domains and how structural racism underlines it all. And then as well as like asking for any additional feedback. But we wanted just to share that we are preparing two manuscripts, one focusing on structural racism and then the other focusing on social determinants of health. And then as well as the September 2024, we have a workshop happening um, in New Orleans to discuss these findings even more and create policy memos and consensus statements so that we can make next steps based on the findings here. And then we'll also be reaching out to CBOs about co-authorships if people are interested. Thank you for listening to this presentation. Um, um, yeah, and if you want to contact me or Tommy, our research coordinator, please, these are our emails. I encourage you to give us your thoughts and feedback on these findings and like, do they align with your experience? How are they different from yours? Is this how you defined how structural racism is affecting your experience, your community's experience, and like how you like I don't know your existence, I guess. Um, and just like any thoughts, feedback that we should add, we would really appreciate it. And so yeah, thank you for taking the time to listen to this. And yeah, that's it. Thank you.